Hi, I'm Dr. Jared Gardner. Thank you so much for inviting me to speak at this meeting. I'm new here in Pennsylvania, so it's nice to virtually be present with some of my neighbors. And I'm loving it here so far, by the way. This has just been a fantastic place to live, so I'm happy to be here. I'm going to just do a whirlwind tour of some various Dermpath pearls and pitfalls aimed at general surgical pathologists, i.e. non-dermatopathologists, some of the stuff that I see people commonly struggle with or be frustrated with. So we're going to try to cover some of those. Obviously, we only have 40 minutes, but I'm going to do my best to get through all of these. And these are my disclosures and conflicts of interest. I don't think any are particularly relevant to this talk, except for the fact that I'm using a lot of images from my Dermatopathology Survival Guide book, and that is published here by Innovative Science Press, and I do receive royalties for sales of that book. And you can see full details of my COI at this link. And these are my 3 daughters, so I'm raising a Dermpath empire in my household. And here's, you can contact me through social media, or if you're old school, you can send me an email. I do have a complete list of all my videos, digital slides, and even I'm releasing sample pathology reports online. And I have these organized into Dermpath and bone and soft tissue at these links here on KIKO, and I do also have a conflict with KIKO. I do receive payments for views of my posts. So if you don't like that, please don't go and see these. But otherwise, you can check them out. It's all available free for anyone who wants it. And I do have a YouTube channel that has the same content on it as far as videos go. So, first category we're going to talk about is tricky keratinocytes. Keratinocyte lesions are bread and butter dermpath. Should be easy, right? I still struggle with them on a basically daily basis, even though I'm a board certified dermpath and I've been in practice getting close to a decade now. So here's one. This is a distal extremity of an elderly sun-damaged patient, and you see something that looks kind of like an epidermoid cyst or follicular cyst, whatever name you like for epidermal inclusion cyst, but it's a little bit complex, right? And to me, when I see a complex cyst, I'm using air quotes around cyst, particularly on the extremity of a sun-damaged person when I can't see the base, that worries me for either squamous cell carcinoma or keratoacanthoma, and that's a whole other topic about whether keratoacanthoma is a type of squam or something different. I usually call most of them squamous cell carcinoma, keratoacanthoma type. That's the way I was taught to do it, but there's lots of controversy over that. So the tip here is beware the complex cyst on sun-damaged skin, especially if you can't see the base of it. I think that's, we don't see cysts on like the forearm that often, and especially if you see one right up close to the epidermis and it's very complex like that, even if it's just no atypia and is glassy keratinocytes like this, to me, I want to see the base of that lesion ideally, or if it depends on my level of suspicion, but I'll add a comment that, this is a cystic squamous proliferation. There's not much atypia, but it's complex. I can't see the base. If there's concern clinically or if it persists or recurs, please excise it or repeat biopsy. That's how I handle those. This I would probably just call squam keratoacanthoma type on the diagnostic line in my practice. Others may do it differently. All right, that looks great for a verruca, right? It's got all the features of wart. It's got para on the top, and it's got papillomatosis, finger-like projections, and some hypergranulosis in here. But then when we look at lower power, you can see, yeah, the top looks like a wart, but what's going on down here? Ooh, that looks pretty atypical to me. So I would say that this is squamous cell carcinoma. And I would say that my lesson here is beware the verruca on sun-damaged extremities, especially if it's transected at the base. Now, I see warts on sun-damaged extremity skin all the time in my practice, and they sometimes get some atypia. I think a combination of sun damage and the viral HPV-related effect on the keratinocytes can make the keratinocytes look kind of bigger and more atypical in warts, especially if they're inflamed. But when I can't see the bottom of it, if it's transected on a shave biopsy, then I'm very cautious, and I'll add some level of hedging there if I can't see the base. If I can see the whole thing and I don't feel there's any carcinoma, then I feel fine calling something a verruca, even if the patient has sun damage. But if it's just the top, cases like this are a great lesson. I always like to look at this and say, imagine I only had a shave that went through this level. What would I have called it then? Ooh, I would have probably said verruca, right? So a lot of times on sun damaged extremities, even if I don't see atypia, I'll say this is consistent with a superficially sampled verruca, but I can't see the base. And even though there's no obvious atypia here, the lesion's broadly transected, and if it continues to grow, if it persists or recurs, then I'd go back and biopsy it or excise it. So sometimes I hedge on things where I can't see the base of a keratinocytic lesion in sun-damaged skin, and I always like to point these cases like this out to my residents in dermatology to show them this is why I hedge, because these kinds of cases can really be tricky. All right. So here's a case where you're having a bad day. You could think that looks kind of like squame. It's glassy. It pushes down into the dermis, but look at all of these. What's going on there? Clusters of neutrophils. And if you look closely, you can find, there they are, yeast organisms. So this is an example. In this case, this is blastomycosis, but other types of invasive fungal infections can produce a similar picture. And so beware the invasive fungal infection that has pseudoepitheliomatous hyperplasia that mimics squamous cell carcinoma. So if it looks like a squame, but you see granulomas and neutrophil microabscesses, go look around, maybe consider doing infectious stain. GMS and PAS are your friend in Dermpath. I've generally used PAS, although for invasive fungi, GMS seems to do better, and it just kind of depends on what stain works best in your lab, or if you have a high suspicion, you can do both. There are certainly times where I'm really worried about infection, and I'll do both stains, and I think that's fine. But yeah, always keep that in mind. Now, that said, I see plenty of squamous cell carcinomas that get little clusters of neutrophils like that, particularly the cystic ones that have lots of keratin in the middle and open to the skin surface, the ones that kind of look like keratoacanthoma. Because some of those, I think, get surface bacteria mixed in there with the keratin, and then they rupture into the dermis, and then you get an inflammatory response. So it doesn't mean, if just because there's neutrophil microabscesses, doesn't mean it's definitely infectious or that it can't be squame, but it should make you pause and think, could this be infection mimicking squame? I've seen good dermatopathologists make that mistake, and I'm sure that if I haven't yet unknowingly, I probably will make that mistake one day, because even really good people can make that mistake. It's very tricky in some cases. All right, now switching gears here, all that is basaloid is not BCC. I think that's what William Shakespeare, or maybe it was J.R.R. Tolkien, said. Just kidding. And in any case, though, it's true that just because it's basaloid and in the skin doesn't mean it's basal cell carcinoma. So here's a classic, obvious basal cell carcinoma, one of the first tumors that everyone learns, I think, in pathology. Blue nests of basaloid cells, and they've got nice peripheral palisading, and there's usually this kind of distinct fibrous and myxoid looking stroma with inflammation sometimes, and clefting around the edge of the nest, all those features that we've learned. Right? So a couple things. Here's another example of basal. Looks great for basal over here, but what's going on here? These big blue pools of mucin. If you're in dermatology, they usually say mucin for this blue stuff. In pathology, we often say myxoid. I use those terms interchangeably. In any case, these blue pools here of irregular size and shape in the middle of an otherwise normal basal cell carcinoma, that's a totally normal, common finding, and it doesn't mean anything, okay? Here's another example, and look at the irregular size and shape of the pools, and very nice peripheral palisading, nice clefting at the edge of the tumor nests with mucin or myxoid stuff present between the basaloid cells and the stroma. Those are classic features of basal cell carcinoma. So what this is called adenoid change. I sign these out personally as basal cell common nodular type, or if there's some other infiltrative area or something else, I'll say that. But I actually don't usually mention adenoid in my report, lest it cause confusion to the treating physician who may wonder, what does that mean? Do I need to do something different? It's just a pattern for pathologists to recognize, to know this looks funny, but it's totally just a normal variant of basal cell carcinoma. There's nothing special clinically about these to my knowledge. The only time I really mention it is if someone had sent me a case in consult. I don't take consult cases anymore, but I used to. And when I did, if someone sent it to me saying, oh, I think it's adenoid cystic carcinoma or adenocarcinoma, then I'd tell them, no, this is just the adenoid pattern of basal cell carcinoma. Now this looks kind of like a basal cell from low power. It does have some cystic spaces filled with keratin, which basal cell carcinomas often have, actually. But when we look closer, you can see that there's this funny cellular stroma and these round to oval stromal cells. These, if you did a keratin, these would be negative. They're actually stroma, not tumor cells, not epithelial cells. And these rounded stromal cells are pushing into the basaloid nest. That's a classic feature. That's called a papillary mesenchymal body. It's recapitulating what you see at the root of a normal hair follicle, the hair papilla that bulges into the basaloid cells of the hair follicle, the germinative cells. And so this kind of tumor is called a trichoepithelioma, a benign hair follicle tumor, much less common than basal cell carcinoma, but certainly not really rare. You do encounter them. So think, if you see see this, that's a really good finding. If you see the papillary mesenchymal bodies, recognize that that probably represents a trichoepithelioma, not a basal cell carcinoma, particularly in patients that are younger or don't have much sun damage. Keep hair follicle tumors in mind. Now, in older adults, if they're old and sun damaged, it has to be a perfect trichoepithelioma for me to call it that. Otherwise, I want to be cautious and make sure I'm not missing a basal cell. To me, if I see papillary mesenchymal bodies, it's trichoep. There are some people, though, who believe that basal cell carcinomas can have these. I just have never seen a case that convinced me of that personally. So I'm a little bit of a doubter, but I recognize that other very smart people disagree with me on that. Now, here's one. It's a big nodule. It's composed of many small nests, as we'll see in a minute. But look at this nodule. It's sharply circumscribed, no connection to the epidermis at all. It's sitting down here on its own in the dermis. And it's got its own unique stroma. I mean, go back to here and look. You can see not only the tumor islands, but the stroma around them is got this sharp, distinct cutoff from the background dermis. So that's not the growth pattern of a basal cell, right? A basal cell wouldn't make this perfect marble of tumor that's completely separate from the surrounding dermis and not touching the epidermis at all. That right away should be a clue that this is probably not basal cell carcinoma. That's not how basal cells grow. And then when we look closer, the stroma is cellular. It has a lot more spindled fibroblastic cellularity. And the cells, look what they're doing. Instead of being split and clefted away from the tumor nest, they're hugging, tightly wrapping around the edges of the tumor islands. We don't see any papillary mesenchymal bodies here, but we do see that cellular stroma clinging to the basiloid cells, just like the stroma does. Go look at a normal hair follicle next time you see one. The stroma around the outside of a hair follicle does the same thing. It clings to the outside surface of the follicle. We call that stroma the adventitia of the hair follicle, and that's what these tumors are recapitulating, that they're regrowing that kind of stroma. So this is another benign hair follicle tumor called a trichoblastoma, and in my opinion, trichoepithelioma and trichoblastoma, both benign hair follicle tumors that probably exist on a spectrum with one another. The name doesn't matter. Recognizing, though, that it's a benign thing and not basal cell carcinoma potentially matters. So if it looks like basal cell, but you don't see good clefting and mucin, and the stroma looks cellular and is hugging the nest, think of a benign hair follicle neoplasm. And a lot of times these are tricky, and if you're not a dermatopathologist, you may want to consider getting a consult at that point, because I think adnexal tumors, Dermpaths, we love them and are fascinated by them. Most other people are like, ugh, please, I don't want to deal with this. But in any case, those are tips to consider a benign hair follicle neoplasm when you see that. And one clue you can use is this, passenger Merkel cells. You can use a CK20 stain, which will show scattered individual cells. You see the whole cytoplasm of these cells is staining, and they're all scattered around throughout this benign hair follicle tumor. I think this was actually a trichofolliculoma, if I recall correctly. But you can see this in a variety of different benign hair follicle tumors, and I find it particularly helpful. There are some other stains people have described, none of which I've personally found that useful. But in any case, I do find the CK20 scattered benign passenger Merkel cells in the midst of the basiloid tumor to be a helpful finding to support a benign thing over a basal cell. Now, what about this? Here's a blue basiloid tumor. I'm not showing you low enough power to see the architecture, but one thing that we can see from here is it's arranged in sheets, and there's really no palisading and clefting at the periphery of the nest, and the nests are not well formed. Again, they're very sheet-like, discohesive in areas, lots of crushed cells and some apoptotic cells, even some necrosis. If we look closer, there's necrosis there. And the tumor cells are molding against one another, and hopefully all these buzzwords right now are ringing the bell in your ear of the diagnosis. And here's another different example just to show you that sometimes the chromatin pattern looks like this, very granular. Other times it looks very fine and smudgy or dusty, salt and pepper if you like. You can use any number of visual cues that you like to describe this. The main thing is that you recognize it when you see it. This is that neuroendocrine pattern of chromatin, and mitoses are usually abundant. So this, of course, is a Merkel cell carcinoma. And to me, the most helpful stain to make this diagnosis is cytokeratin 20, which will show dot-like positivity in many cases, although sometimes the dot-like pattern is not perfect or is only focal. That doesn't matter. If it looks like a Merkel cell and you see CK20 staining, even focally, that is strong support that what you're dealing with is indeed a Merkel cell carcinoma. There you can do other stains. I usually will just, if it looks great for Merkel and I have CK20 positive, I used to just do that. Now I'll usually add on a TTF1 just to make sure I'm not missing a metastatic small cell from the lung, which I've now seen a few cases of in the skin. It's pretty rare, but it does happen sometimes. Although, of course, those will not usually be CK20 positive. They'll be CK7 positive. So if I do a 20 and it's positive and it looks like a Merkel and TTF's negative, I feel comfortable just calling it Merkel cell carcinoma. Other people would do a broader panel. That's up to you on what your comfort level is. I have a video on that page on KIKO and also on my YouTube channel about how I approach Merkel, so you can check that out if you like. If CK20 doesn't stain, then I expand my panel and do some other stuff to prove it. Sometimes basal cell carcinomas can have some neuroendocrine looking cytology. So just be aware of that sometimes that does happen, but if an architecture looks good for a basal cell, just finding some of this granular chromatin doesn't worry me too much. But if I am worried, I'll do a CK20 to rule that out. I would caution you against doing synaptophysin or chromogranin, because sometimes basal cells can show some neuroendocrine differentiation, and then you're in a real difficult position of how to explain that to the treating physician, because basal versus Merkel is a huge difference in prognosis and treatment. All right, so keep Merkel cell in mind. It's out there and it's sneaky and it's easy to miss. Now here's a basaloid kind of island, and it looks like there's actually a not really good palisading, but there is a little bit of clefting here, and there's mitoses. So you could get concerned about basal cell. If the cells were closer together, you could even think a little about Merkel. I've seen this tumor mimic Merkel cell before when there was only a small piece present. But look down here, we got some giant cells. And look over here in a different part of the specimen, we see these sheets of pink ghost or shadow cells that basically are sheets of dead keratinocytes that have left behind the outline of the cell borders and of the nuclei that have all dissolved and gone away. Calcifications are often present. Giant cell reaction is usually robust because these fragments of keratin spill out into the dermis, and the dermis and the immune system do not like free-floating keratin, and they tend to make this robust granulomatous response anytime there's free keratin present. And so, of course, putting these all together, the granulomatous reaction, the sheets of ghost or shadow cells, and then this transition into blue basaloid cells. This is a pylomatracoma or pylomatrixoma, whichever name you like. And mitoses are often abundant in pylomatracoma, and that does not in any way worry me for malignancy unless I see severe nuclear atypia or atypical mitotic figures. A bunch of mitoses, I see that all the time in pylomatracoma, and it's totally fine. Look for the ghost or shadow cells. That's the key to the diagnosis. And I'll point out that the amounts of these three components can vary from tumor to tumor. Sometimes you have abundant blue basaloid cells, and those are the cases that can really scare people because they see all these blue, round blue cells and all these mitoses, and then they get really worried. Other cases will be just the ghost shadow cells with giant cell reaction, sometimes with a lot of calcification and even ossification, bone formation, with no basaloid cells at all. So the basaloid cells are only there in some cases. Sometimes it's totally burnt out and all you've got is this dead stuff and the reaction to it left over. So, and these are of course more common in children, but I've seen them even in elderly adults. So they can certainly occur in pretty much any age range. Now here's something that looks kind of basaloid also. Again, the morphology is not, from low power, not perfect for a basal cell carcinoma. Don't really have good palisading and clefting. And if we go closer, they're pretty ugly nuclei. And there's also all these bubbles, some of which they're clear, they're sharply circumscribed, and they indent the nucleus. Some even look like signet rings, mitoses everywhere, including kind of atypical figures. So this is a sebaceous carcinoma. Sometimes sebaceous carcinomas look very basaloid and can kind of resemble basal cell carcinoma or poorly differentiated basaloid squamous cell. In other cases, like this one, this is a different case, can look much more squamoid and actually really mimic squamous cell carcinoma. But here you can see at these arrows, definite, nice, bubbly, vacuolated sebaceous that are very obvious even on H&E. But over here, if you just gave me this picture, I'd call that squamous cell carcinoma any day of the week. So if you see something that has an ugly, looks like an ugly squame or has overlapping features between basal and squame, especially if you're on the face near the eyes, where sebaceous cell carcinomas often occur, I always try to think of sebaceous carcinoma in that setting. Now the problem is this. Some tumors are obviously sebaceous, but you have a hard time telling are they benign or malignant. Other tumors are obviously malignant, but you have a hard time telling, are these vacuoles enough to call it sebaceous, or is that just kind of some artifactual vacuolation in a squame or a basal, which, by the way, I see all the time, unfortunately. So I've written papers about this, and I should know how to do this, but I still struggle with this a lot in practice. I think they're very difficult sometimes to be sure if there's sebaceous differentiation in a carcinoma. Some stains that I've found helpful, but none of which are perfect, is EMA, adipofillin. If you have that, that's actually quite nice. And nuclear expression, or nuclear staining, excuse me, of factor 13A, which we actually were the first to report and describe in the literature, but only it works if it's clone AC1A1. It's some unusual cross-reactivity that stains the nuclei of both benign and malignant sebaceous in the vast majority of cases. But with practice, as I've used it since we published that paper, I've seen it sometimes have patchy staining in squamous cell and other things. So again, the reason we have so many markers is because none of them are perfect. So if I have any doubt, if I say I see a case like this, and I'm not sure there's just a little bit of vacuole, sometimes I'll say invasive carcinoma. This could be a basal cell or a poorly differentiated squame, or a squame with basiloid features, but I can't, there's some vacuolation and I can't exclude sebaceous. The point being there that this is a carcinoma that could potentially behave more aggressively, and it should be treated more aggressively clinically, completely excised with negative margins, rather than just, curetted or treated with a more conservative procedure. So I do sometimes say that is invasive carcinoma, see comment, with the comment that, this is probably just a basilar squame, but sebaceous or other adnexal carcinoma can't be totally excluded. So I certainly have cases where I have to make comments like that and have a kind of hedgy comment, unfortunately. But it gets the job done for patient care, so it seems to be okay. If you have to do that, you have to do it. All right, now let's talk about melanocytes, which obviously is the pitfall that really concerns people and brings the most angst because it's high risk, and in the litigious environment that we practice in, it's even more worrisome. So let's talk about some melanocyte basics and how to try to stay out of trouble, okay? First of all, recognizing what melanocytes are and telling them apart from keratinocytes. Sounds easy, but a lot of times people struggle with this. Even I see practicing pathologists sometimes struggle to tell these apart, but there's a simple trick to tell them apart, okay? It doesn't work all the time, but it works much of the time. Both keratinocytes and melanocytes tend to make vacuolation artifacts when we process them in the laboratory, but the type of vacuole they make is different. Keratinocyte vacuoles are around the nucleus. The nucleus is floating in the center of a space, an empty space with a sad, lonely little keratinocyte nucleus, all naked and alone with no cytoplasm around it. Or sometimes keratinocytes have a signet ring look where you get kind of a crescent-shaped squished nucleus and then a clear space around it. And I don't understand why those vacuoles happen in some cases and not in others. There's probably some good histology, chemistry explanation, but I've never fully understood. But what happens here is that the keratinocytes cytoplasm is filled with keratin, which is an intermediate filament that hooks onto the desmosomes, which hook onto the neighboring cell. So when the cells shrink, the cytoplasm can't move. It's stuck to the outside of the cell, so the nucleus shrinks away from everything else. That's the take-home point there. Melanocytes, though, don't have all those keratin filaments and desmosomes, so what happens when they get shrinking during tissue processing? The cytoplasm clings to the nucleus and hugs it, so you get this blob of pink or gray cytoplasm that sticks onto the nucleus, and is kind of feathery and wispy, sometimes spidery like this. So that grayish pink cytoplasm clinging to the nucleus, that's a sign that you're dealing with the melanocyte, or sometimes other cells like Langerhans cells can produce a similar effect, so sometimes that can be a little tricky to sort out. But this is pretty easy most of the time to tell apart these keratinocytes and melanocytes with their vacuole artifact, and I've got a video if you need to refresh this or you need to teach it to your residents. Feel free to share that with them. It's a short little 5-minute video that points out some nice examples of this. And in a difficult case, of course, you can use immunostains to sort them out. Now, let's talk about some of the features of melanoma, all right? No single feature alone microscopically makes a diagnosis of melanoma. There are exceptions to all of the rules, but some of the things I look for as clues are asymmetry from right to left. If the right side of the lesion looks different from the left, that's a clue that maybe it could be melanoma. Pagetoid spread, confluent growth or predominance of single melanocytes, lack of maturation, cytologic atypia, and mitotic activity. These are kind of the main features I'm looking for when I look at a melanocytic lesion. In my mind, I kind of run through this list to see, is any of that stuff stand out to me there? And if so, then I need to look closer and think about it more and decide, could it be a melanoma? Okay? But of course, you have to take it all into the context of the clinical, the age of the patient, the site, all that stuff, which is why Dermpath is hard. And some days, even for me, I'm like, man, I thought I was going to get better at this one day, but it's still so hard and I still struggle. So thankfully, I'm surrounded by really smart colleagues to help me out. Now, let me show you examples of all this. So here's pagetoid spread. You couldn't ask for better than that. Obviously, in this case, we have definitely a melanoma in situ, ugly atypical epithelial melanocytes with lots of pagetoid. There's even a mitosis in here that looks kind of like a little frowny face or something. And so that's what pagetoid spread looks like. Sometimes you see nevi with rare pagetoid cells, that, especially if they're rubbed or scratched or irritated, that alone doesn't make a melanoma. A couple pagetoid cells in an otherwise normal nevis, no problem. I see that all the time, like almost daily probably. But you do have to stop and think about it, especially when you see pagetoid and you've got sun damage. Look at all that solar elastosis there. Be extra worried when you see melanocytic things in sun damaged skin. Okay? And do remember that other things have pagetoid spread too. Squamous cell carcinomas, or Bowen's disease as some people call it, is probably the most common thing I see with pagetoid spread. And also, of course, Paget's disease of the nipple or extramammary pages in the anogenital area. Now, this is what we mean by confluent growth, when you have solitary melanocytes and sometimes nests also that are kind of replacing the basal layer of the epidermis. In practice, it sounds simple, or I mean, when we talk about it, it sounds simple. Oh yeah, the melanocytes replace the basal layer. But I find that in most cases in practice, it's really difficult to definitively demonstrate confluent growth. The best time to see it is in acrolentiginous melanomas. They tend to have really dramatic confluence, but elsewhere, confluence is a little bit in the eye of the beholder. And this case is a pretty nice example where we have a predominance of single, very atypical melanocytes replacing much of the basal layer. So when you see that, you should get worried. Here's an example of what we call the blistering or unzipping artifact. It looks like a melanocytic lesion with a, quote, subepidermal blister, but it's not a real blister. This is an artifact from processing, because look, there's no inflammation, there's no fibrin, nothing in here that you would expect if you had a real blister in vivo. So what's happened here, and there's also, look, pagetoid spread and atypical melanocytes. But what happens here is when confluence becomes so dramatic that it replaces most of the basal keratinocytes, during processing, the epidermis separates from the dermis because there's not enough hemidesmosomes left over to hold the epidermis down to the dermis. So I'm still not totally sure why this doesn't actually happen in real life patients. I almost never have seen real true blister formation in vivo in melanoma patients, but we see this relatively often in melanomas after histologic processing. So I'm not sure why that happens, but in any case, if you see a melanocytic lesion with a split like this, you got to go and rule out melanoma, because that's a very concerning feature for melanoma. And again, this is an acral lesion here, so you really see it best, I think, in acrolentiginous melanomas. And here's an example of abnormal maturation. Obviously, this one, another one that's an acrolentiginous melanoma. There's tons of confluent growth and pagetoid spread over here. And here we have these big nests of big melanocytes that go down, and there's still huge, massive nests. And if we went to higher power, we'd see there's still very large nuclei way down. Normally, melanocytes get smaller and more spaced out and dispersed into small nests and single cells the deeper you go in a nevis. So in a benign nevis, that's the normal, what we call maturation pattern. Melanomas tend to have big cells and big nests even down at the bottom. Now, this is, again, a really dramatic, perfect example. In real life, discerning maturation between nevis and melanoma in tricky cases can be quite challenging, I think. But at least I want you to know this is what we're talking about when we say abnormal maturation. This is like the hallmark textbook, best possible case example of it. In real life, it's not going to usually look this good. And of course, you all know how to look for pleomorphism and atypia and mitotic activity. Like, look, you don't usually find these huge, massive atypical mitoses in a melanoma. This was a massive nodular melanoma, if I recall correctly. And I mean, you could karyotype that. There's like 530 chromosomes in that melanocyte there. So, but if we see mitoses, particularly if there's many mitoses, deep mitoses in the deep dermal aspect of the lesion, or atypical mitotic figures, those are all bad, concerning signs for melanoma. You have to be a little bit more careful when you see mitoses in the epidermis, because it's a lot harder to tell there if you have a mitosis actually in a melanocyte or if it's in a background keratinocyte, which is a normal finding we would expect in the epidermis. So dermal mitoses are what we're usually looking for, but if you see them in junctional nests, pay attention to that. That does raise some concern for the possibility of melanoma, but usually the dermis is what we want to find. So look, we're not going to go into dysplastic nevis. It's much too controversial and frustrating of a topic to cover. But just to give you an idea, I think as most of you know, the bridging of nests from reedy to reedy and this pink fibroplasia around them or lamellar fibroplasia or fibrosis. That's the kind of classic features or the architectural pattern that we look for in so-called dysplastic nevis, which has been, many different names have been proposed, but I still call them dysplastic nevis in my practice. So that's what a dysplastic nevis, real nice, I think most people would agree that that would fit with what's called dysplastic nevis. That's what it looks like. The reason I'm pointing that out is this kind of looks like that, right? We have long redi, nests of melanocytes down the redi that are bridging together. But there's a couple things here I want to point out. There are some melanocytes crawling up here into the interredi space, which gets me a little nervous if I see that. But what's even more important is this. Look at all the solar elastosis here. So this is from the face of an old person. I guarantee you, if it looks like a dysplastic nevis and it's on the sun-damaged face of an older person or the scalp of an old person that's got sun damage, that is almost certainly not a dysplastic nevis. And I have seen that mistake made multiple times. Do not call things dysplastic nevis on the sun-damaged head and neck unless you're totally sure, or even I will do it occasionally, but only when I see the whole lesion and I've done stains and I've done everything and I've shown my colleagues, and then with great trepidation and fear, I'll say, okay, I think despite the age and the sun damage, I think it's probably a dysplastic nevis, but if it recurs, you need to excise it, or I add all sorts of hedging language around it. And so I feel like even in patients that are like dysplastic nevis syndrome patients where they have lots of dysplastic nevi, I don't often see dysplastic nevi on the face or the scalp, even in younger patients. So already I'm going to be suspicious. The ear would be one exception. The ear is a weird site and nevi there look funny, and I see things that look like dysplastic nevis on the ear, but on the sun-damaged face or scalp of older people, be very wary of calling anything a dysplastic nevis, because here's that same case, and look, as we come over to a different part of the lesion, we see confluent growth, not in the epidermis, but down a sweat duct. This is a sweat duct here. You can't really see the duct very well. At a closer look, you could see the little lumen right there. But confluence down follicular or eccrine duct structures is a good sign for melanoma and can be really helpful in these melanomas in sun-damaged skin. So these are classically called the lentigo maligna type of melanoma, or in the more recent WHO skin book, the chronic sun damage pathway of melanoma. And they can sometimes have this dysplastic nevis-like architecture and have nesting and elongated redi with bridging. So the main take-home I would say is if it's the sun-damaged face or scalp of elderly patients, I would strongly advise against calling things dysplastic nevis unless you're just totally sure or you've shown it to a Dermpath expert, because you will be wrong most of the time in my experience. The exception would be that I do sometimes on the shoulders and the arms of older sun-damaged people, I see lesions that otherwise look perfect for dysplastic nevis, and I feel more okay. I still am more cautious when I see a lot of sun damage there, but I do on a regular basis see dysplastic nevi that have probably been there for years and just gotten cooked in the sun on the shoulder or the forearm of an older patient. But again, I really want to look at those more closely. I may do stains and levels, and depending on if I can see the edge of the lesion or not, I may use some different amounts of hedging in my comment. All right, so there's a more classic example here of a lentigo maligna type of melanoma, and it's got single cells with confluence and also nests. And look at the lymphocyte aggregates. Lymphocyte aggregates are host response against the melanoma. That can be a really useful clue. If I see, even from low power, I start seeing a bunch of lymphocytes around the epidermis, I go down and look closer, because that's a clue that the lymphocytes are unhappy with something there, and I want to go make sure it's not a melanoma, that they're unhappy with. And here's a closer look. This one had actually very nice confluence. A lot of times lentigo maligna get a lot of vacuolation and kind of angulated nuclei in them. Some cases are much more subtle than this. This is a really nice characteristic classic example, but again, more subtle cases exist, and those can be really challenging. Now, I want to also point out that lentigo maligna doesn't have anything to do microscopically with solar lentigo. Clinically, lentigo maligna, which is melanoma in situ, can look, or it can be invasive also. Melanoma, lentigo maligna type, can look like a lentigo clinically, which is where historically this name came from. But I have sometimes found pathologists and trainees who have been confused by that. Solar lentigo is actually a proliferation of pigmented keratinocytes, and it has elongated redi that usually have this boot or hockey stick kind of shape. And sometimes it looks like there's little nests here. Don't confuse those with nests of melanocytes. Those are actually just a tangential cut of these little redi tips. And look at all the pigment. Melanocytes paradoxically, they usually lack pigment or have very little bit of dusty brown pigment. There are exceptions, but I would say much more often when you see a heavily pigmented brown cell in the epidermis, it's usually a keratinocyte, not a melanocyte, contrary to what you might imagine. And likewise, in the dermis, really darkly pigmented cells are usually histiocytes, melanophages. Macrophages are histiocytes that have eaten up that extra melanin rather than melanocytes. And there are exceptions to the rule, of course, like always. So this is a solar lentigo, and these are benign, but they often get biopsied because they're on sun-damaged skin of elderly patients. And so the dermatologist will send a biopsy and say pigmented lesion, lentigo versus lentigo maligna. It's a common specimen that I see multiple times per day in my practice. So learning to sort those out is really helpful if you see any amount of skin pathology. And sometimes solar lentigos can intermingle with actinic keratosis, pigmented AKs particularly. That's often, I will see both present on the same biopsy. So sometimes solar lentigos, this is like kind of the classic pattern. Other ones can be atrophic. I'll show you in a minute. This is a wordy. This is just so that you have in the handout, which I've provided to the meeting organizers, so you can download this and have it at home for reference. This is a table of how I like to use melanocytic immunostains for different scenarios. It depends on what I'm trying to prove or look for, and I'll use different stains based on that. And this is just my opinion. This is the world according to Jared, or how I like to do it. So you can check those out. And I didn't really address PRAME here. I've only been able to use PRAME in the past year or so. I quite like it. It does work pretty well, but I've definitely seen melanomas that didn't have PRAME, and I've seen nevi that express PRAME. So nothing's perfect, but it is an extra tool to use in ambiguous melanocytic lesions to help us sort them out. All right, now this is what you want. And in a classic ideal world, this is a perfect example of what you want to see in a melanoma: confluent growth and pagetoid spread. And there's also intradermal stuff and probably a little bit of background nevis down here, and the nests of invasive melanoma here. And this is confluence up. It goes down the reedy, up the reedy, down the reedy, up the reedy, like a kid took a red crayon and just marked all along here. If you have the red chromogen, I like that, but you can use brown if that's all you have. It can be harder to interpret when there's a lot of pigment present in the background epidermis. I love SOX10. It's one of the stains I use the most in my practice. But if you don't have this, MITF also works, and you can use MART1, although I think it's more challenging to interpret personally. So here's an example, a solar lentigo. Like I said, sometimes they have elongated reedy, but other times they're flat and thin and atrophic. So it looks so pigmented, but when you do a stain, look, all you have is scattered melanocytes that are interspersed by a lot of keratinocytes. So that's really reassuring. So if you have a doubt, you can do a SOX or an MITF and easily tell that you're not dealing with a melanoma. Now, there are cases where it's hard to interpret this because in sun-damaged skin, you can get an increased number of melanocytes, what we call solar-induced melanocyte hyperplasia. And that's where it becomes much more tricky and nuanced, and it takes a lot of experience of looking at those and getting used to the density and the increased density and enlargement of normal background melanocytes that happens in patients with a lot of sun damage. So here's an example: chronic sun damage, face lesion in an 80-year-old white man. And what's the diagnosis and what's the stain? Well, you might say, gosh, that looks like confluence and pagetoid spread. But this is an S100 stain. And look, S100 is supposed to look dirty because there's all these Langerhans cells that live in the epidermis and also get down in the dermis and some other dendritic cells. So those will all stain with S100, which is why I do not like using S100 to look at the epidermal component of a melanocytic lesion. It's going to scare you to death because you'll see all that stuff. Here's the same case, same area of the block, stained with SOX10. Look at the dramatic difference. That's why I like SOX10, okay? I don't make any money I don't even know who all manufactures SOX10. I just use it in my practice, that's all. So I don't think I have any conflict of interest with those immunostain companies, to my knowledge. All right, so in any case, that's what I do. And this is also useful that in intradermal tumors of other sorts, sometimes people do S100 and they'll see scattered staining. It's normal to have scattered S100 positive cells in almost any lesion, especially if it's in the skin and there's inflammation or ulceration over it. But if you have any doubt about, is this S100 too much, just do a SOX10 and compare it, and all that staining will disappear. That means it was all dendritic cells, not melanocytic, okay? And here's what MART1 looks like. MART1 is a cytoplasmic stain, and because of that, it's going to have more staining in the epidermis than SOX10 because it stains all of these dendritic branchy processes that melanocytes have that go from the melanocytes to the neighboring keratinocytes. And you're going to see a lot more density there. And it's going to, if you're not familiar with the pattern and with a threshold of interpreting this, it's going to make people, oftentimes can make people want to overcall things as melanoma that are not. So here's a contrast. Again, same case. Look at MART1 or Melan-A if you like. It's basically the same thing. And here's SOX10 on that same case. And look at the dramatic difference. All right, so let's talk, finishing up here, let's talk about some tricky spindle cells. This is a spindle cell lesion on the scalp. It goes, you can see the thin epidermis, the whole dermis, and subcutis, all the way down to the galea aponeurotica is replaced by spindle cells. From low power, you should right away think of the diagnosis once you've seen a few of these. You can see there's fat that's been totally replaced by tumor. And look at these lymphocyte aggregates. Spindle cells with a slightly bluish myxoid background on the scalp with lymphocyte aggregates. Looking closer, we see scattered pleomorphism, again, the lymphocytes, and look, if we're lucky, we'll find some mitoses if you have a big enough sample, but sometimes they're very sparse. Putting all that together, this is desmoplastic melanoma. These are very treacherous lesions because they have a lot of collagen and myxoid material that separates and spaces out the individual melanocytes. Only a subset of the melanocytes has pleomorphism or atypia. Some of them look very small and bland. Pretty much all the spindle cells you're seeing here are actually melanocytes. Maybe a few fibroblasts mix in. But it can be really, really hard sometimes because they can be bland and they're not very cellular. So you have to have a high index of suspicion when you see something that looks like a scar but has atypia or has mites or has lymphocyte aggregates or they are on sun-damaged skin and there's not a good reason for them to have a scar there. Always think of desmo. These are relatively rare, but they're out there and they're really, really easy to miss. Look at that. That's a desmoplastic melanoma right there. The top of one very similar to the one I showed you from low power. So beware of the apparent scar on sun-damaged skin. If you start seeing hyperchromasia, do an S100 or a SOX10. Okay? They can also look very wavy and neural. They can look so much like neurofibromas. And in fact, desmoplastic melanoma versus a neurofibroma with scattered degenerative atypia is, to me, one of the most challenging spindle cell differential diagnoses in Dermpath. And I'm speaking as someone who also does soft tissue pathology. I find them very hard to separate out. Immunostains are not terribly helpful there. So if you see what looks like a neurofibroma on sun-damaged skin, which I see them regularly in older sun-damaged people, but if you start seeing atypia, be very careful. Look around. If you find even one mitosis in something that looks like a neurofibroma and it's on sun-damaged skin, you should really think twice because mitotic activity is very, very low in neurofibromas. So mites are going to be your most helpful clue, or if you're lucky, you'll find a melanoma in situ component. Now, here's a desmoplastic melanoma that did have melanoma in situ, but about half of cases will lack this, which is really difficult, okay? So the lack of melanoma in situ does not rule out desmoplastic melanoma. But what I also want to show you about this slide is look at the diffuse S100 staining in the dermis and look on MART, totally negative except for a couple little nests up here. So in desmoplastic melanomas, they almost always are negative for the specific melanocyte markers like MART1 and HMB45. So S100 and SOX10 are the markers that you want to use there. So that's all the stuff I just told you. And when 90% or more of the tumor looks like the stuff I just showed you, we call those pure desmoplastic, but sometimes they're present with epithelioid or spindle cell melanoma component, and then we say that they're a mixed or combined desmoplastic. The reason that matters is that pure desmoplastic melanomas actually have a somewhat better behavior on a depth-by-depth basis to other melanomas of conventional type. When they're the same thickness, the desmos are somewhat better, have a lower risk of metastasis, but they can be quite locally aggressive. Like I've seen one grow through the skull and into the dura before, but the patient still didn't have mets. Really crazy. Very, very different behavior from other types of melanoma. Okay, real quick point about spindle cell melanoma. Sometimes people get desmoplastic and spindle cell confused. The difference is desmoplastic should have the cells separated by that collagen in between. They should be relatively hypocellular, whereas spindle cell melanomas, basically, they look like a sarcoma. You look at this and you're like ugly spindle cells and fascicles or sheets, clearly malignant. You don't wonder that this might be a scar. So if you look at it and you think of sarcoma and then it stains like a melanoma, guess what? That's spindle cell melanoma. Okay, they sometimes express MART and HMB45, but I find that oftentimes they have partial or complete loss of those markers too. So I regularly see spindle cell melanomas that are only S100 or SOX10 positive, and then people will want to call them malignant peripheral nerve sheath tumor. No. MPNST almost never occurs in the skin, and certainly not, I would never personally call something MPNST in the sun-damaged head and neck of an older person. No way. That is melanoma all across the board. Also, MPNSTs usually don't have diffuse strong S100 and SOX10 expression. They're usually either negative or weak patchy staining, which is paradoxical. I have a whole long, like hour and something video about MPNST where I preach about all of my favorite points about it. So if you want to learn everything and more than you wanted to know about MPNST, you can go check that out on my channel. And sometimes the spindle melanomas tend to make these packets that kind of are like something between a hybrid between a fascicle and a nest. I like to call them nesticles, if that works for you. And my residents always laugh, so I keep saying it. But whatever works for you, I hopefully that didn't offend anyone. All right. Now, finally, the last thing, and then we're done. I know I've gone a few minutes over, my apologies. Rashes, ugh, everyone hates them, right? Even as a dermpath, I do find rashes sometimes very frustrating because it's sometimes hard to make a definitive diagnosis. I think for general pathologists, thankfully, you don't usually have to make a definitive answer, but just helping the derms sort out what patterns are there and what might fit or might not fit with their clinical differential can be enormously helpful while you're waiting for a dermpath consult if it's a challenging case. I have a whole video on kind of a basic 101 approach to inflammatory rash dermatopathology for general pathologists, how to approach them and learn the patterns, and then all the nuance you can deal with later or never if you don't want to. But learning the basic patterns is really useful at first, and there's the link to it down there, so you can check that out if you want later. Now, here we've got something that's got a lot of lymphocytes. So, don't just say chronic inflammation in the skin. Don't call stuff acute and chronic inflammation. Right away, the dermatologist will know that you do not have much experience with dermpath probably because we don't usually use those terms. Just describe what cells are there. It's lymphocytic infiltrate or lymphocytes and plasma cells or neutrophilic infiltrate. Just be descriptive, but acute and chronic don't really work the same way in the skin as they do elsewhere in pathology because you can have acute things that are lymphocyte driven and chronic things that are neutrophilic. So this really doesn't work. Now here we have the epidermis is kind of acanthotic and thickened. The rete are elongated and even a little bit psoriasis-like. But there's also this huge thick lichenoid band of lymphocytes. But when we go closer, unlike a regular lichenoid band, there's not very many dying keratinocytes, maybe like one. Normally lichenoid things like lichen planus have lots of dead and dying keratinocytes, little blobs of pink along the basal layer. But here we don't. And the lymphocytes are really trickling up into the epidermis. And when we go closer and look around the vessels deeper down in the lesion, we find there's a lot of plasma cells. So when you see all these features together, you should always think of this. And this is a spirochete immunostain. So this is Treponema pallidum. This is syphilis. Syphilis is having a massive resurgence. The incidence of it has increased multiple times over the past 10 to 20 years. I think that it's like 400% greater incidence of syphilis now than it was 15 years ago or something like that. I can't remember the exact numbers, but it's a lot more common. So it's out there. It's easy to miss. It can mimic lots of different things clinically and microscopically. This is a real classic example, but some cases don't have this. If in doubt, get a stain or tell the clinician, please do a RPR or other serological test because syphilis is easy to treat and it's potentially really bad if it's not treated, both because of the risk of spreading it to other patients and also because chronic syphilis can progress on into very problematic, tertiary stage, which is rare nowadays, thankfully, because we often catch it and treat it, but can be really bad for patients if it's missed. So I have a low threshold for doing a syphilis immunostain, and I only occasionally find it. Out of all the stains I do, only a small percentage actually end up being positive, but I want to make sure I don't miss it. So don't forget about syphilis. It's out there and it's easy to miss, particularly those of you who see anogenital biopsies. Always think of it there when you see something that looks lichenoid or when you see, plasma cells are common in those locations. But if you see anything that makes you think of syphilis, I have a low threshold for doing the stain. Well, that's a whirlwind tour through some pearls and pitfalls in dermpath. I hope that you enjoyed it. Thanks very much.